Hello to everybody who's in the session today. My name is Eric Slim. I will be the chair of today's session on disability. I will be joined by my co-chair, Janine Ebenso. She has been working for the Leprosy Mission International for almost 33 years, I saw. And she's a former physiotherapist and has a PhD, a master in disability studies. Myself, I'm a rehabilitation doctor with a PhD in leprosy. I want to discuss with you the housekeeping rules for the session. There will be 3 presenters, and they will have this presentation of 8 minutes, and we have time for 6 minutes question and answers. I want to ask you to send your questions in the chat box so Janine can have a look at them and we can come back to the questions afterwards. So if you don't have any questions now, then I would suggest to start with the first presentation. That is the presentation of Mr. Karthik on removable offloading device versus total contact casting to promote healing of plantar ulcer in leprosy. It's a randomized controlled trial. So, Mr. Karthik, the floor is yours.
Thank you, Dr. Eric. Let's start sharing my screen. Once again, thank you everyone. Good afternoon, good evening, and some of you good morning. I'm Karthik from the Leprosy Mission Trust India. On behalf of all the investigators of the study, I present the study titled Removable Offloading Device versus Total Contact Cost to Promote Healing of Plantar Ulcers in Leprosy. This is a multicentric, non-inferiority randomized controlled trial. As we all know, the plantar ulcer is a common and severe complication in leprosy that often neglected in terms of amount of research done when compared to other complications seen in leprosy. Point prevalence of ulcer is estimated to be over 30% among those with loss of sensation in the foot. If you see any leprosy hospitals, you will see over 50% of hospital admissions and bed days are utilized for ulcer. It's such a time and resource consuming complication. We all know that the continuous plantar pressure is a reason for ulcer. Also, this is one of the main reasons for delays in the wound healing. Therefore, the rest of the affected part is very important if you want to promote the ulcer healing. The gold standard to rest is the total contact cost, but unfortunately it has several disadvantages because to apply a total contact cost, we really need a good skill, and often it can give you unfavorable outcome in terms of skin abrasion, etc. if you don't apply it properly. And also it requires a constant monitoring. Unfortunately, the expertise of applying this plaster cast in the leprosy hospitals are dwindling these days. There is a need for an alternative. The removable offloading device works the same way as the total contact cost, but it is removable and easy to use. Therefore, the research question of this trial was, is a removable offloading device as effective as total contact cost in promoting the healing of non-complicated plantar ulcer? Non-complicated plantar ulcer we mean here is the visibly non-infected ulcer. This was a multicentric, non-inferiority randomized control trial. We recruited the ratio of 1:1 into both control and intervention group. This study was done in the 3 tertiary hospitals in the hospitals of the Leprosy Mission Trust India, one in West Bengal, one in Uttar Pradesh, one in Delhi. This trial was registered in the clinical trial registry of India before the commencement of the first participant. The calculated sample size was 150 patients, 75 in each group. The study was carried out between June 2022 to February 2025. This was the intervention we provided. Wherever there was ulcer, we cut out the insole. The insole was made of ethyl vinyl acetate, EVA. And wherever there is ulcer, we cut out the insole to promote the offloading. That cutout insole was inserted inside the offloading device. Then patient is allowed to wear this. This cutout part actually gives the offloading of the ulcer area. In the control group, we provided the total contact cost, that is a standard care that is provided here. which is applied with, we apply POP and apply the plaster cast with window over the ulcer to promote the ulcer dressing daily. Also, we apply the ball or iron to allow the patient to walk to promote ambulation. So this was the intervention and the control group. And the inclusion criteria was the patients aged 18 years and above with loss of sensation in the foot with non-complicated plantar ulcer. That should be suitable for the total contact cost, which is determined by the treating physician, usually the surgeon in the treatment the study centers. Exclusion criteria were ulcer on the non-plantar area of the foot. When there is a multiple plantar ulcer, when offloading the index ulcer compromises the healing of the other ulcers, we excluded those patients. If there is a visible signs of infection and sinus tracts, we excluded. If there is a vascular compromised foot, they were excluded. And if there is a limb length discrepancy or amputation of the contralateral limb, we excluded them from the trial. This slide shows the study flow. We screened patients with non-complicated plantar ulcer. When they are found eligible, we took the consent and we asked the patient to get admitted in the hospital. Then the baseline assessment was done. Baseline assessment included demographic data, clinical data related to leprosy, and ulcer metric in terms of photograph taken and duration of ulcer, whether it is a recurrent or the first ulcer. And then we also measured the quality of life. And they were randomly allocated to either intervention group or the control group. And they were followed up every week. Every week we did the ulcer metrics. We took the photograph to facilitate the ulcer healing later. And also we measured the user satisfaction with the validated tool at the completion of the study or at the achievement of ulcer healing. The endpoint to this trial was complete healing of ulcer or completion of 6-week follow-up, whichever was earlier was the endpoint to the study. The primary outcomes were the number of completely healed ulcer at 6 weeks. The second primary outcome was reduction in the ulcer area. The secondary outcomes were the user satisfaction with the intervention, functional independence level, and quality of life. So in this presentation, the study is complete, the data to be analyzed by the statistician. In this presentation, I will present the one primary outcome and the one secondary outcome. And I also present the adverse events. So progress so far, the target sample size was 150. We recruited 151. Their final follow-up also is complete. Analysis to be done. The data collecting is in progress. So this slide shows the consort diagram. So we screened 422 patients with ulcer. Of them, 151 patients found to be eligible. They consented and they were randomized. 74 in the removable offloading group, that is the intervention group. One did not receive the intervention because the foot was too short. We were not able to give the offloading device, so he was excluded. And 70 patients received the intervention. In the total contact group, there were 77 patients. 4 patients were not willing for POP, so they were excluded. So 73 actually received the intervention. Of the 74 in the removable offloading device, 8 were lost to follow-up, and 65 patients completed study. None of them were excluded from the analysis. Everybody was included. Whereas in the control group, 10 patients were excluded for various reasons, and 63 patients completed the study, and all of them were included in the analysis. This slide shows the study participant characteristics in terms of demographic data. At baseline, we can see the male and female were sort of 3:1 ratio. They're equally distributed between both the groups. And mean age in the in the intervention group was 45 years, whereas in the control group 42 years. There was no difference. Majority were from the rural areas. Again, there is no difference between the group. And mean height and weight was similar between the group. And the education level, almost 2/3 of patients never been to school or studied only up to primary school. So the distribution between the two groups also is similar between them. And the median duration of disability was 5 years and 6 years in the control group. Again, was comparable. Median EHS score represents the severity of disability, was comparable between the group. Median foot score, that is a foot score in the EHS score also was comparable between the group. In terms of distribution between the right and left was similar between both the groups. Majority of the ulcer was in the forefoot. Again, this was similar between the both group. And ulcer recurrence, almost 40% of ulcer was the first ulcer, whereas remaining were the recurrent ulcer. Again, the distribution between the first and the recurrent ulcer between the two groups was comparable. This just shows the randomization really worked well. And this forest plot shows the first outcome, that is percentage of ulcers healed at 6 weeks. In the x-axis, we show the two different groups, control and the treatment group. And in the y-axis shows the percentage of ulcers healed by 6 weeks. In the control group, 75% of ulcer healed by 6 weeks, with a confidence interval between 64 to 85%. Whereas in the treatment group, it was 66% with a confidence interval between 55 to 78. We also show that the non-inferiority margin of 20%. As you can see, that the confidence interval between the two groups is overlapping. So we can say that there is no statistically significant difference between the two groups in terms of percentage of ulcers healed at 6 weeks. This slide shows the risk difference. When we calculated the sample size, we said that the risk difference will be within 20% to establish the non-inferiority. So the difference was calculated as percentage of ulcers healed in the treatment group minus the percentage of ulcers healed in the control group. So the difference was 8%, minus 8%, with the 95% confidence interval between minus 24 to 7.3. Although the difference was, the estimated difference was well within the non-inferiority region, that is below 20%, minus 20%, but the confidence interval was very wide. The lower limit of the confidence interval was slightly outside the non-inferiority regions. It just shows that the non-inferiority aspect of this removable offloading device is sort of uncertain. This slide shows, this forest plot shows the secondary outcome, that is user satisfaction with the intervention. We use the cubic assisted device satisfaction scale, which is a validated one, which has a score between 0 to 40. Higher the score indicates the greater the satisfaction with the device. And in the y-axis, we show the two different groups. You can see that the mean user satisfaction in the treatment group was 38%, 38 with a 95% confidence interval between 37.5 to 38.8. And the control group, the mean score was 34.9 with the confidence. We can see that the confidence interval is not overlapping. There is the user satisfaction in the treatment group was statistically significantly higher. This slide shows the.
Can you round up the presentation?
Yeah, just one more slide.
Okay, thank you.
Yeah. This slide shows the adverse events in the removable offload device. The skin redness of skin was observed in 3 patients, whereas in the total contact cause, skin abrasion was observed in 1 patient. Worsening of ulcer was seen in 3 patients. 1 patient had a fall. This is the interim conclusion. The percentage of ulcers healed at 6 weeks in the removable offloading device is comparable to the total contact cost with a higher user satisfaction. Adverse events were minimal in the removable offloading device compared to total contact cost. The non-inferiority of the removable offloading device is sort of uncertain because of wide confidence interval, maybe because of the more loss to follow-up as estimated sample size calculation. Although the trial did not provide enough statistical evidence on the non-inferiority, the treatment is clinically relevant, comparable to the total contact cost, and easy to use and safe. The challenges were recruiting female patients were very challenging. They don't want to stay in the hospital. Recruiting patients from outpatients also was challenged because they are expected to stay in the hospital ulcer healing. And many patients are not willing to stay till the healing hours. When the ulcer becomes small, they want to go home. Monitoring data was very challenging without a clinical trial unit. And this all some of the key references. And I would like to thank St. Francis Leprosy Guild and Leprosy Research Initiative for funding this study. And I also like to thank Leprosy Mission Great Britain and the Effect Group, who actually fund our time in the Leprosy Mission Trust India. Thank you, Chair. Thank you.
Thank you, Mr. Karthik, for this very interesting presentation about the subject. Also very interesting for the diabetic foot care, whereas the same discussion is going on. So, Janine, do you have any questions in the chat box? I think there weren't any.
There are none in the chat box, no. I do have one from myself, though. You've mentioned the results are interesting, and wondered, do you have any information on the relative cost of the intervention compared to using a normal plaster of Paris?
Yeah, we do have a cost of it, but we haven't done any formal analysis. But we have some model, not from this study, from other study, in terms of evaluating cost. So, we will do that later. As of now, we don't have.
Okay, thank you. So if you have any other questions, please put them in the Q&A and we'll take them at the end of all three presentations. Thank you.
Yep. And then we will continue with the next presentation from Dr. Michael Pallapati, who will be presenting a study about personal footwear for preventing plantar ulcers in leprosy, a community-based approach using a Baropodometry. The floor is yours, Mr. Michael Pallapati.
Greetings to you all. Thank you, Dr. Eric, Ms. Janine, my fellow presenters, and those who have logged in online. I want to share about our project, which is funded by, yes, of course, LRI, personalized footwear for foot ulcers in leprosy by Baropodometry through an innovative community engagement model. It is from last April 2023 till September 2025. To introduce plantar ulcers in leprosy, there is a common complication leading to grade 2 disabilities among 10 to 20% of leprosy patients in India. The current practices include self-care, wound care, and regular usage of MCR footwear. The challenge is that to integrate it into the foot pressure analysis for its prevention, and there is a need for effective prevention by adapting this technology for better ulcer prevention strategies. What is Baropodometry? Foot pressure analysis technology that helps identify areas of pressure imbalance, potentially preventing ulcers. In the current state, early stage studies show potential but limited evidence and effectiveness for leprosy patients. Our research goal is to test the software enhanced MCR footwear with Baropodometry for ulcer prevention in leprosy patients. The primary aim is to compare standard MCR footwear versus software MCR footwear with Baropodometry for ulcer prevention. It is a multicentric two-arm cluster control trial, which is undertaken in 3 states, Andhra Pradesh, Odisha, and Bihar, among the self-supported groups. And the participants are the leprosy patients aged more than 18 with a history of current plantar ulcer. There are some other photographs from the field where you train the community research persons to capture the foot imprints using Harris mat. As part of the project, we also trained the PSC staff and the ASHAs, accredited social health activists who work in the community on self-care, so that beyond the project period, they will be able to help people affected by leprosy to continue and to motivate them to continue the self-care practice. To the extreme right on top is the customized footwear, which is done based on the Baropodometry imprints. We also provide the self-care kits, which has the Vaseline, gauze, bandage, and also scissors. And this is the self-care training of the people affected by leprosy within the project at the PSC. And we have completed the baseline as part of the follow-up visit the patients, study participants at their doorstep, and inquire with them about their foot health, examine their feet, their footwear also, and check with them how they practice self-care. Also encourage the ASHAs and also the paramedical staff working at the community level to touch on these study participants, all those who are affected by leprosy at the community level, to check with them whether they are practicing self-care. Data collection expected outcomes. We are through with the baseline assessment where we had the clinical aspects, the medical history about the foot health, and their perception about their practice of self-care and social well-being. And now, since last July, we are doing the follow-up monthly assessments of ulcer recurrence and footwear adherence. This is done by our project coordinators and the outreach workers at the field level. The expected outcome from the project is reduced ulcer occurrence and improved self-care and better adherence to footwear and reduced disability and enhanced quality of life. Key findings and challenges. The sample size is 288 participants, 144 in the intervention arm and the 144 in the control arm. Progress to date is, as I told you, it is baseline assessment completed. Now we are doing the follow-up, which will be continued till June of this year. I mean, under 2.5 months. Preliminary findings indicate that the lower ulcer rates with software enhanced MCR footwear, and there is a positive patient feedback on comfort and foot health. The challenges are that adherence to footwear use in rural areas because of their occupation. They find it difficult to use the footwear when they go to work. And the other thing is our staff are also involved in national leprosy program activities. So sometimes they're busy with that work. Impact and next steps. Research impact validates the potential of baropodometry in leprosy ulcer prevention. And policy impact, we expect that it will influence leprosy control programs to adopt technology enhanced footwear down the line. Social impact, improved quality of life, reduced disability, and greater independence for leprosy patients. Next steps is to continue follow-up till June of this year and analyze the full data set. We also plan to develop ulcer risk stratifications tool and the NLR survey of the study participants. And then we also plan to have the disciplinary meetings with stakeholders while the project comes to an end and submission of the final project report to LRA by September of this year. So thank you so much.
Thank you. Thank you for being on time also. Janine, do you have any questions in the chat box? Or
there are none in the chat box, but Bob Bowers has put one in the sorry, it's not in the Q&A chat box, but there's one in the chat box. So please put them in the Q&A section, which is at the bottom of your screen. So from Bob Bowers, do you have the minimum thickness of the MCR for both groups and the Shaw measurements of the MCR? So that's for you, Dr. Michael.
Janine, please come again, Janine.
Do you have, if you look in the chat, it's there. I don't know if everybody can see the chat or if it's just the panelists. Oh. Do you have the minimum thickness of the MCR?
8 millimeters. 8 millimeters.
Okay. And what is the Shaw measurement? SHORE?
I think it is 10 millimeters MCR and 8 millimeters of the outer surface. Shaw is 40.
Shaw is 40. Thank you. And then we've got one that's just come up in the Q&A from Mr. Jairus Ralph Beja. Who creates the customized footwear? Is it included in the capacity building of health workers?
We have trained shoe technicians in LEPRA. So the PT, the physio technician, will advise as to kind of the customization that needs to be done. So our trained shoe technicians who are trained in leprosy customize the footwear.
Thank you. Thank you.
Yeah, any other questions? Otherwise, I have a question concerning the economic aspect. Do you have any idea about cost effectiveness of the intervention you performed?
Dr. Eric, other than the once we have procured the equipment for enhancing the customers' footwear, which is the Harris mat and the software that we have, there is not much of difference between customizing it conventionally and customizing it based on that. Only the equipment cost is the initial capital investment that we are going to have.
Okay, thank you. If there are no other questions, we'll go on into the third and last presentation of Dr. Arup Chakrabartty. He will be performing a study on the effectiveness of peer support approach-based basic psychological support on NTDs. So the floor is yours, Dr. Arup.
Good afternoon. I am Dr. Arup Chakrabartty. I am the National Research Coordinator of NLR India. So our study's title is Establishing the Effectiveness of Peer Support Approach based basic psychological support for NTDs to address mental well-being, stigma, and social participation of persons affected by leprosy and lymphatic filariasis in Jharkhand, India. The short title is Basic Psychological Support through Peer Supporters for Leprosy and Lymphatic Filariasis. So the background, NLR India conducted a proof of concept study to identify the effectiveness of basic psychological support for persons affected by NTDs among persons who were having disabilities due to leprosy or lymphatic filariasis, and the support was given by peer supporters in two areas, Jaunpur of Uttar Pradesh state and Bokaro of Jharkhand state, in the year 2021 and 22. During this period, this is a short-term study of 3 months pilot study, and this study showed promising result to improve mental well-being and the different stigma outcomes, to reduce the stigma outcomes. So being inspired from this pilot study, the current study wants to identify a complementary, effective, and sustainable way to achieve mental well-being and generate rigorous evidence. That is why we propose to test the efficacy of BPS-N intervention through a cluster randomized control trial. Now, in this research, our main research question is, how effective is basic psychological support for persons affected by NTDs through peer support to reduce stigma, improve their mental well-being, and social participation among persons affected by leprosy or lymphatic filariasis, compared with the arm where they are not supported by peer supporters. Now, the objective of our study is to evaluate the effectiveness of BPS-N-based peer support for addressing stigma, mental well-being, and social and work participation of persons affected by leprosy and lymphatic filariasis. Method. So this is a cluster randomized control trial, and it will take place in two high endemic districts, Jharkhand, in Jharkhand state. The districts are Pallamo and Garhwa districts. It will be a cluster randomization technique where the randomization will happen at the block level. So we'll have stratified random sampling method where we'll have to select 16 blocks, 8 per district, and then from the 16 blocks we'll randomize to select 2 intervention blocks and 2 control blocks from each district. We'll have a total sample size of 640, out of which 50% from leprosy affected and 50% lymphatic filariasis, and each arm, control and intervention, will have 320. We'll also ensure that 50% women participation comes from this sample. The sample size for the qualitative data collection will come from 38 peer supporters, 38 clients, and 12 stakeholders who will give their opinion data. Now, the quantitative data will be collected through different scales, 5 in numbers. One is Warwick Edinburgh mental well-being scale. Another is patient health questionnaire, 9 items. Another is general anxiety disorder, 7. The another is Surrey stigma scale, and another is participation scale, short simplified. Qualitative data that will be conducted through interviews and focus group discussion, and data will be entered into a REDCap database. And for quantitative analysis, we'll use data. This is the flow chart of the study protocol. Once we get the ethical approval, then peer educators will be selected. 16 persons will be from leprosy and 16% will be from lymphatic filariasis. In the phase 1, they will be trained. After they are trained, we'll conduct the baseline data and we'll prepare the baseline report in 2 districts, Garhwa and Pallamo, which are intervention districts. Now we'll have cluster randomization of the blocks as I described earlier. We'll have 2 control blocks and 2 intervention blocks. And in each arm, we'll have 320 clients. 160 will be leprosy affected and 160 will be lymphatic filariasis. And they will ensure that 50% women participants are there. Now, in the control block, we'll have no intervention, and in the intervention block, we'll have peer supporters. Those there will have peer-led intervention for basic psychological support. At the end of the phase 2, we'll start data collection, and during the implementation phase also on quarterly basis, we'll be having follow-up data collection. In the phase 3, we'll collect the data for doing an end-line study and do impact assessment, end-line evaluation, and followed by final report preparation, and we'll disseminate that among different stakeholders to influence the policy for greater implication of the study. Now, progress so far in 2024, the project gained momentum through continuous advocacy with the state government. But despite there are some delays, the delays are due to the fact that in this study, we are dealing with two types of things. One is disabilities related to lymphatic filariasis and leprosy. On the other hand, we are talking about mental health. So we have to align stakeholders from different units of the health department. So it took a lot of time. That is why recently what we did, in 2024, we got the approval from the Institutional Ethical Committee of Rajendra Institute of Medical Sciences. The State Leprosy Officer of Jharkhand helped us to do this. Following this, we have already in an advanced stage to get the administrative approval, which is expected to come by end of April this year. And for the recruitment, hiring of staff, we have already prepared the terms of reference. We have floated the advertisement. CVs has been shortlisted, and we have prepared the interview schedule. By end of this month, our hiring process will be complete. So then we'll start the implementation in the field itself. Now, about the timelines, we request for no cost extension that we have mentioned in our annual report also. So the administrative approval, then constitution of the technical advisory committee and standard operating procedures, and registration of this study in the clinical trial database, that will be over by June this year. And then training modules of adaptation and training of peer educators. We are hopeful that we will be able to complete by this year, end of this year. Then during the intervention, collection of tools, quantitative. I was talking about 5 scales. Those we will be applying for follow-up and end-line also. So all the participants will be included, we think, by March 2026. And the intervention, actual intervention, will be over by end of April. And then we'll go for the final data collection of the end-line study, followed by the final project report preparation. That will go for conduct workshop for dissemination of our findings to, to go to the broader platform for policy recommendations. So in the conclusion, I would like to say that despite initial challenges, even though there is delay, the project has got some strong ground because we have got the institutional ethical approval and the administrative approval is coming very shortly. The research findings will provide critical data for policy advocacy, and hopefully that will integrate the mental health services into the NTD programs, which is unique. Now, this long-term goal, the impact of the study will be that the mental well-being, and that will reduce the social stigma, contribute to inclusive healthcare policies for the state of Jharkhand and beyond that in other states of the country. I have to acknowledge Rajendra Institute of Medical Sciences and Dr. Ajay Baklov helped us to get this ethical committee approval. SLO Jharkhand and the admin and accounts officer, Vesel office, who helped us to collaborate with different departments to get this thing, and that is why delay happened. They helped us a lot. LRI, who is providing resources, NLR International Office for providing technical support, and GLRA, who is partner of this study. So with these acknowledgements, I thank. That's all.
Thank you, Dr. Arup. Yes, research is always challenging, as you mentioned. Don't think there are any questions or
there are a few coming through in the Q&A.
Okay. Otherwise, I have one, but let's start with you.
So the first one, and I think we need a clarification on the question, is what is the validity and reliability of the scale? I mean, you mentioned quite a few scales, so I'm not sure which, maybe the person asking the question, kgs through 3, can actually indicate which scale they're asking about, because most of the ones listed, I think, have been validated.
Yes.
So I'll ask Bob Bowers his question, which is, how long do you expect the assessments to take at pre and post intervention? You've listed a lot of tools to use, so how long do you expect the assessments to take pre and post assessment, pre and post intervention, sorry.
Yeah. So about the validation of the tool, yes, the tools are validated, particularly I can just cite this SARI stigma scale, general anxiety disorder scale, patient health questionnaire. And as I mentioned that we had a proof of concept study, which is the background and basis for this larger scale study that we have proposed. So the tools are validated, I would say.
And they're validated in all the languages you're using, yeah?
Yeah, we'll use in the local language definitely to make
Have they
it,
been validated in each of those languages?
Yes, in the proof of concept study that we did, so that was used in local language.
Yes. Thank you.
And how
Then
much
the other
time?
question was, how long do the assessments take?
The initial assessment, as in our roadmap, we have proposed that by end of June this year will be.
I think the question is related to how long will you need to be with each person? How you're using a lot of tools, so how many minutes or hours is it going to take to finish all those assessments?
I understand. So the time usually that will take, it will not be more than half an hour, because the Warnick Edinburgh tool that has that is a 14-item questionnaire, which is 1 to 5 scale, so 14. So the expected time is half an hour. So all the 5 tools, they will not take more than half an hour time to conduct the interview.
Half an hour each.
Half an hour for each person. That it will not exceed more than that.
Each tool or each person? Each
person.
Okay. That I've not had experience using all of those tools altogether, but that seems
it may vary.
That seems ambitious, half an hour.
Yeah.
It may vary.
Okay.
But the 5 questionnaires, out of that, some questionnaires are for service providers and some questionnaire for patients.
Okay.
Okay. Are there any other questions? Because I'm interested if you suspect any differences between leprosy and the filariasis, because you have these 2 groups, which are, can imagine there are in some way comparable concerning stigma, but there are also differences, very rigid differences, especially in leprosy with beliefs, etc. But do you think what will be the influence of these differences in your study?
Yes, we have. I really appreciate your concern, sir. Particularly, 2 disease has a different type of morphological characters, and associated stigma with that will be different.
Yeah.
And during the analysis, we'll try to disease-wise disaggregated information we'll like to prepare, and we'll try to see what is the difference that insight we'll get from when the study will be complete. A baseline study will be complete.
Okay. Thank you. No more questions. Then we'll round up a bit more early. I want to thank you, the 3 speakers of today, and also Janine for helping me. And thank you for your attention, and I hope you enjoy the rest of the LRI meeting today and perhaps tomorrow. So thank you. And
thank you so much. Thank you so much, Janine.
Till next time. Good luck with your research.
Thank you so much.
Thank you so much. Thank you.